So I just got here to the office and I remembered I have to report a few emergency CT scans. If you are interested, just tag along. Let's see what we can find out, what we can report on these exams. Let's go. I'll share with you the screen. I have already downloaded the first exam. This is a lumbar spine of an elderly female patient. She is 54 years old and complains of lower back pain, which is really common. So there is a odd looking last lumbar or sacral vertebra. Let's see, this is the last rib. So this is L1, 1, 2, 3, 4, 5. So this is a S1 anomalous vertebra. Now, this is a transitional S1 vertebra. Let's describe it right away so we don't forget about it. S1 transitional vertebra. It has a rudimentary disc and some anomalous joints, partially fused joints right here. So this is in a site of lumbar spinal instability, which leads to early degenerative disease. So there is degenerative disease all over, but this is probably the cause of the start of the disease. Rudimentary disc and so there is osteophytes, reduced intersomatic spaces, and a bunch of herniations. There is a herniation right here. There is another herniation right here that goes from neuroforamen to the other side. There is also a herniation right here. There isn't much of a herniation here, so let's see which is which. As L1 to L2, tiny herniation, not very important. Yep, this one is a herniation. So we have on 3 segments disc extrusions, posterior disc extrusions, partially calcified, which reduce the size of the neuroforamina on L5S1, but not so much on the other segments. And the spinal canal is also reduced in size. There is chronic atrophy of perivertebral muscle. This is chronic denervation. It's really common. We have severe arthrosis of the facet joints. So severe arthrosis, especially here on the transitional section of the spine. Anomalous joints all over the place. So these are bad joints. Yep. Thickening of yellow ligaments. And this is it. Facet joint arthrosis and osteophytes. So let's report it. Feel free to skip ahead to the next case because I'm going to speak to myself and report the case as of right now. You might, if you stick around, you might learn something else, but it gets quite boring, so some people prefer to skip ahead. There are chapters, timestamps on the description below, and I guess on the progress bar also, so feel free to do that now. It's okay, I'm not going to be mad about it, I do the same. So there is vertebral canal stenosis, and there is neural foraminal stenosis at L5S1, which is expected because this is a transitional vertebra. Hypertrophy and liposubstitution of perivertebral muscles. Yep, this is it. Severe osteoarthrosis of facet joints, chronic stenosis of this vertebral spine, and hypertrophy of the perivertebral muscles. So we are done here. This report is signed and we can go to the next case. So let's get a chest CT scan of a male patient. He is 67-year-old and complains, and his doctor says he has a pneumonia. So let's see if he indeed has it. Let's download the exam. Fingers crossed it's going to be fast. Let's grab a template for elderly patients' chest CT scans. This is it. Yep. Chest CT scan. It's downloading quite fast. Only 5 seconds left. Yep. Its recording is going fine. So we have soft tissue window and lung parenchyma window side by side. Let's scroll up and down. Oh, this patient has some chronic illness of the lungs. These are linear atelectasis of the cortical regions of the lungs. Some very little anomalous content on lower lobe bronchus, airways, just like this. Thickened walls and partial filling of the bronchi, just like here. So this is an acute bronchopathy, bronchopathy, or something like that. I can't really pronounce it properly. There is some subpleural blobs of air and discrete, very mild signs of emphysema on the upper lobes and some pulmonary bands, which are very, very common on the elderly. So there is some very tiny acute pulmonary disease, mostly airway disease. So, yep, no adenopathy, no adenopathy. Lymph nodes are all right. So let's just hit the MPR and look for any sign of bone lesions we have possibly missed, so we don't miss it. No, not missing anything. Rib cage is fine. Scapulas are fine. Shoulder blades, scapula in Latin, are fine. There is degenerative disease, of the spine as always, because he is 67-year-old. So 67 years old should have degenerative disease, degenerative disease of anything really. It's time for that. There is a tiny calcification right here. It is a tiny scar, calcified scar. This is of no significance. So linear atelectasis on cortical regions, mostly on the upper lobes. Some signs of anomalous content, anomalous feeling of airways, especially on the lower lobes. Some atherosclerotic disease of the aorta and the coronary. He also has left-sided gynecomasty. Really tiny. I could even let it go, but this is actually showing much easily than on the right side, so I'll report it. And this is it. This is what we have for this patient. So I'm going to report this case. Feel free to skip ahead or stay with me if you want to learn a bit more as I mumble to myself and report this case, okay? There are chapters on the description below. The emphysema, and subpleural blobs of air. Those on the upper lobes. Linear atelectasis. Wall thickening and anomalous feeling of bronchi, especially on the lower lobes. And calcification. Yep. Aortic and coronary atherosclerosis. This is already here because this is a template. So let's just make it short on the end of the report so the doctor can read it faster and be happy about it. I just summarized the entire report in a few sentences so the doctor can actually go through the report much faster, and if he is actually interested in the report, he can go up and read the actual text of the report, the longer description. So this makes my life a bit harder, but the referring doctor is usually much happier than if he had to read the entire report every time he orders a CT scan for one of his patients. So it's a good thing. After all, in the end, it's good. It's a better job to be like that. Now I'm typing, and this is it for today. This is it for this case. Let's sign it. Let's clear these images and go for the next one. So the next one is a abdominal CT scan, emergency abdominal CT scan of a 50-year-old male that complains about right-sided abdominal pain, and the doctor thinks he has a kidney stone on the way to the bladder, on the ureter. So this is an unenhanced CT scan of a male patient. Just fix my my light right here. Yep, it's okay. The download has ended. We can load the images, and yes, this is an unenhanced CT scan. Fine. Let me get my template for young male abdominal CT scans. So just pasted my, yep. And we have liver and spleen. This is very clear. There is liver hepatic fatty deposition. There is at least a mild, I can say this is a mild steatosis of the liver, and indeed there is a stone right here on the transition from the pelvis and the first portion of the ureter on the right, which makes it very clear this is actually the cause of the right-sided pain of the patient, as his doctor has mentioned on the exam ordering. So the appendix is alright, is normal. Right here, the appendix, there is some mild liver fatty deposition. So he has mild fatty liver disease. The prostate has some tiny calcifications, which is okay. This is expected. Colon is alright. Great retroperitoneal vessels also alright. Adrenal glands are fine. The spleen on the left side is okie dokie. The pancreas, as much as we can tell, is fine. This is the stomach, the gastric chamber, duodenum, bowel, and colon. So, what we have here? We have a mild to moderate dilatation of the renal kidney calyces, I don't know how to pronounce that, the urinary system, drainage system on the right. There are two micro stones, calculi, right here, two on the lower pole of the kidney, and another stone right here on the transition from the pelvis to the ureter. This is called the pielo-ureteral transition. In Portuguese is transição ureteropielica or pielo-ureteral. So this is Portuguese. Portuguese is pretty close to Latin, and from Latin we make it an English word, but as you have may noticed, I'm not a native and I can't pronounce, I don't know how to pronounce, how to say a bunch of medical terminology, so I'm learning as much as you guys. So, yep, this is the single stone. This is the only stone that is lodged, stuck on the right ureter. So this is probably going to be a surgical patient. We can hit MPR. The MPR button makes it a sagittal and a coronal exam by reconstructing the images in a beautiful way, and we can see right here the stone is really stuck inside the ureter right before the crossing of the ureter through behind, right before the ureter crosses behind the inferior vena cava. So this is a pielo-ureteral transition junction site. So this is the urinary bladder, which is partially filled with liquid urine, and the approximate distance is over 20 centimeters or 200 millimeters. So let's report this case. Now feel free to skip ahead if you don't want to listen to me mumble and report this exam. Although if you stay, I can tell you can actually learn a bit more, because I tend to discuss with myself as I report and type the report. Okay, I might say a few words in Portuguese because I'm reporting in Portuguese. I'm in Brazil. So let's report the liver steatosis. Now, for those of you that are in doubt, are not believing me, so this is liver, parenchyma, 44 Hounsfield units, and this is spleen, 54. So the liver is slightly hypoattenuating in comparison to the spleen. So this is fatty liver disease. And next up, there is no hydronephrosis nor stones on the left, but there is 2 microstones, 2 microcalculi on the lower pole of the right kidney. Oh, yep, and the culprit, the cause of the entire suffering of the patient is this right here. So I'm going to measure its attenuation. It's almost 1000 Hounsfield units, and I'm going to measure it on the axial plane, because the coronal plane, the reconstructed MPR coronal plane, may distort the images, and I may measure the stone in a exaggerated way, making it harder for the patient than it actually is. So this is a 5 millimeter stone and 1000 Hounsfield units, so it's pretty solid. Oh, there is hydronephrosis on the right because of this calculus, this kidney stone, this calculus. Calculus is Greek for stone, as far as I remember. So I tend to say calculus because in Portuguese we don't really say stone, which is pedra. We say cálculo, which is the fancy word for stone. So from doctor to doctor, when we're speaking of disease, of kidney stones, we don't say pedras nos rins. We say cálculos renais, which are kidney stones or kidney calculi. So this is because I have to stop and mumble a bit to actually say the correct word in English, because I'm thinking in Portuguese. So what else? Yeah, partially filled urinary bladder, and the appendix is okay. All right. So, yep, this wraps it up. Oh, status I have to say here. Yep. Right. So we're done. Let's sign it, clear the buffer, and get ourselves another CT scan so we can get a head CT scan now. This is a 57-year-old male patient. This is a head CT scan. It says he had a stroke. There is a previous exam right here, so I'm going to download it also so we can check. I'm also going to grab my template for old man's brain CT scan, because of course I'm not going to waste my time typing in stuff that always shows up on search scans. So let's load today's images. So this is a pretty messed up scan because patient clearly did move his head while the scan was being performed. So there is a bunch of movement artifacts. The closest to the bone window we get, it's easier to see how much this patient moved his head while the scanner was doing its thing. So to avoid this kind of behavior, you should properly position the patient on the table and attach a strap. There is a cloth strap, a fabric strap to the head of the patient. So the head of the patient is held secure on the position. You can actually scan the patient. In some hospitals, in some clinics, there is no such strap. It's usually a very old scanner, or it has been lost or broken and never replaced. So people tend to get tape, some paper tape, and tape the patient's head also to the table of the scanner. But most of the times when we see cases such as this, it's just because the technician doesn't care. He doesn't care enough to actually position the patient properly before scanning him. So we have to work with what we got. So this is what we got. A very, very badly done CT scan of the head, but I can readily tell you there are no signs of stroke. Not hemorrhagic stroke nor ischemic stroke. So there is no actual bleeding that I can see. This is just old man's brain. So let's get the last exam. So this is the previous exam. This is the previous exam. Yes, this is today's exam. So previous exam was also pretty badly done, but with less movement artifacts, but it was also malpositioned. So this is pretty much the same scan. We can say that there is the brain is reduced in volume, is atrophied. There is mild dilatation of the ventricles, some hypoattenuation of the brain's white matter, which points towards chronic white matter disease, which is very, very common in the elderly. Also atherosclerotic change to the carotid arteries. And this is it. Let's check the eye sockets, which are terrible scanned, and the petrous bone, temporal bone. So it's, as much as we can tell, it's okay. So this is just old man's brain, nothing major, and in comparison to last time's exam, it's really the same. So I'm just going to quickly report this, and feel free to skip ahead to the next chapter of this video if you are interested. So mild, and this is it. Mild dilatation, mild white matter disease, atherosclerosis, and in comparison to last exam, não há nada de novo. There aren't any new signs. There isn't nothing new. So let's sign this exam off. Clear cache. It's taking a bit to sign it. And let's open the next exam for today. We are 32 minutes in the recording. Excuse me. Yep. Let's go for a angiography, a chest angiography, a arterial pulmonary scan, contrast enhanced, of course, on the search for acute pulmonary arterial embolic disease, embolus. So I have a template, of course, for this. This is a male patient. He is 66 years old, and all I have of prior history of this patient is pulmonary thromboembolism, pulmonary acute thrombosis of the pulmonary arteries. I really don't know how you people say this in English on a routine basis, but we in Portuguese call it TEP, which is short for thromboembolismo pulmonar, which is in English pulmonary thromboembolism. So the images are almost here. We have to wait just a few more seconds, 5 seconds, 4, 3, 2, 1, and we've got it. Let's load them. Yep. So this is the arterial, pulmonary arterial phase. This is the pulmonary arterial vessels are much brighter than anything else, and we can see that the trunk of the pulmonary artery is fine, the main pulmonary arteries as well, and we are going to follow up and down all of the branches and ramifications to look for some kind of filling defect. So if there are filling defects on the pulmonary circulation, of course, we can tell there is acute pulmonary thrombosis, which is a very, very serious disease, very serious emergency, medical emergency. So be aware of the middle lobe arteries, which are horizontal and can be kind of misleading. So we can hit MPR and see if we find anything, especially on the sagittal plane. The sagittal reconstruction really helps a lot. So let's put it here, compared to this side, so you can see what's right and what is left. So this is left. The vessels are right here, so I'm going to increase the zoom. So zooming in and looking for arterial filling defects. You can see this isn't a perfect MPR because this isn't a perfect acquisition. This isn't a very good machine. It's just a 8-bar, a low-end machine, but it isn't a problem to report this. It is quite common in Brazil, and I guess all over the world. Not every diagnostic radiology clinic or hospital or department has state-of-the-art CT scanners and MRI scanners, of course, because they cost too much money. They usually don't pay for themselves. They are just a lot of cost and not much profit. So yep, sagittal doesn't help. Let's see coronal. I'm not really worried about coronal. And I know you guys must be screaming on your chairs and in front of your television and screaming to the screen of your smartphone because you think I haven't noticed the massive pericardial effusion. I have, and I'm going to report it. Just settle down. We are looking for vascular diseases, not pericardial effusions. Come on, focus. So there is no arterial thrombosis of the pulmonary circulation. There is a large pericardial effusion, which could be the cause of the chest pains and all the symptoms and the signs the patient must be complaining and showing off to the doctor. So we are going to report it as a additional finding on our angiography scan report. So there are no signs of acute pulmonary arterial thromboembolism, but there is a large pericardial effusion. And this is it. Let's sign this off, clear cache, and report another abdominal CT scan. This is nice. So this is a 38-year-old female patient. Let me just hit download. This is a contrast enhanced abdominal scan it says she has had a bariatric surgery and a reversion, a undo. She had it undone. Oh, this isn't something we see every day. This looks like trouble. This shouldn't be easy. So let's get a template. Let's suffer during the work, not before it, and see what we can actually take from this exam. So this is a large exam. It's downloading really fast. We are less than 50 seconds from looking at the images. So let me open up some more information about this case, and I'll tell you guys what I'm reading right here. So it's doctor's writing. You can't really tell much. It's impossible to read. This is just some impossible to read writing from some kind of doctor somewhere in Brazil, so it just doesn't help much. So we know this patient has gone through bariatric surgery 10 years ago and had it reversed about 20 days ago. So it's less than 10 seconds to get here, the images I mean. So it's done, downloading, it's done. So let's open up. Yep, there is a portal, enhancement phase, and a pre-contrast phase, which is more than enough for diagnosis. I don't know what the patient is complaining about, so I don't know what I'm looking for actually. So it's just a post-op, just a post-op surgery. This isn't good, really isn't good. I don't know what they gave the patient here, but there is some kind of contrast, attempted contrast enhancement of the gastric fundus and the anastomotic site. So this patient is fat, is still obese, and got her gastric surgery reversed. I don't get it. Yeah. And she didn't hold her breath. There are a bunch of artifacts. This is a tough one. I can regularly say that there is some fluid collection on the left hypochondrium, the left upper quadrant of the abdomen, right beside some kind of suture to the ball, and right beside the suture of the gastric pouch. There was anastomo that was joined together with the rest of the stomach, as in reversing the gastric bypass. So this is the cause of the pain. This is most probably what the doctor is looking for. So we're going to do our best to look for disease. This is probably the entry point of the surgical instrumentation. That's why it's densified like that. Or that this might have been some kind of intracavitary drainage device that was used not long ago and was taken out. So this is scar tissue. The gallbladder is gone. There is no major liver disease. The pancreas is okay. Oh, yes, pancreas is okay. Spleen, kidneys, and great vessels, and adrenal glands, they are all fine. Portal vein is fine. There is no ascites, and there is no liquid free fluid. I don't know if it's ascites or ascites. It's free fluid in the abdominal cavity. I'm pretty sure I have already listened to Google Translator, so Google can teach me how to pronounce medical terms in English, but I can't really remember because it's really easy for me to just mistaken it for the Portuguese pronunciation. So I did a MPR, so I can actually measure that fluid collection more confidently, properly. So see, this is a awful looking exam, but we can tell there is a thickened, irregular walled fluid collection on the abdominal cavity on the left upper quadrant that goes from the bowel to the gastric fundus to the gastric pouch anastomosis, and it measures about 68 millimeters on one axis and about, let me see, about 54 on the other. So 54, 68, this is more than enough. Let's report it now. So the gallbladder is gone. I can say there is post-op signs on the stomach and the bowel. There is oral contrast, ingested contrast. I have to say it on the report. I'm just going to describe the fluid collection on the abdomen. Feel free to skip ahead if you find this boring. I'm going to mumble to myself and report this. So there are chapters on this video, on the description below, and on the progress bar that send you ahead to the next exam. It's okay, I'm not mad. I'm not going to be mad at you. Just go if you want to watch the next case, or stay here with me and watch me report this case, which is kind of boring for some people, but it's also a learning experience. Fluid collection. So I described the fluid collection adjacent to the sites of surgery, which is probably blood, a collection of blood, and intestinal and gastric fluids all together because of the surgical procedure. This is quite common, and if this gets bigger, it's usually drained surgically, and if it gets smaller, it's usually left on its own until it turns just into scar tissue and it's done. So abdominal surgery isn't a stroll in the park. It is a very, very serious matter. So shit does happen sometimes. So, yep, just see that is diffuse densification of the greater omentum next to the collection. I have to add that. I'm going just to summarize the report in the end, just to make the referring doctor's life easier. And I left a footnote saying that this tiny amount of oral contrast that was given to the patient to drink didn't get out of the stomach, the gastric chamber, but it's really not the case. On the contrary, usually this has to be severe disease, really brutal disease, for the contrast to go from inside the stomach to outside into the abdominal cavity. So this kind of strategy, this kind of contrast enhancement really isn't of much help. It really doesn't help anyone. It's just a thing that doctors like to order. I really couldn't care less. It doesn't help me on any way. It just makes my life a bit harder. So this is it. This was a pretty uncommon case of post-op abdominal CT scan. So let's sign this off, clear cache, and get a head CT scan. Why not? Just to settle down a bit. So this is a 57-year-old patient. It's a female patient, and we are looking for stroke related signs. She also has a previous scan a few days ago. I mean, less than 24 hours ago, actually. And I'm going to open up today's scan and download yesterday's images so we can actually compare. So let's go. Yep. It looks okay to me. There's some calcification of the internal carotid arteries, but there isn't much to be said about the brain parenchyma. Brain is fine. So if the brain is fine, let's see the orbits, the eyeballs, the sockets, the orbits, the masticatory spaces, the upper portion of the neck, bone window, look for bone lesions, fractures, and whatnot. There is arthrosis of the temporal mandibular joints, which I'm not going to report because this isn't a exam for that. Let's not distract ourselves away from the main purpose of this exam. I wonder if in the last report another doctor said this patient had any signs of stroke, because it seems she has been admitted to the hospital as if she had a stroke. So let's just see yesterday's report from another doctor, which says she is fine, and I agree, she is fine. She isn't sick. Her brain is just fine. I have a template that I can just copy and paste because it's rather common to have an exam right like this, so it's useless to just type the entire report if I can just have a template. And I'll just add a follow-up phrase saying it's okay, it's fine, it's unaltered, it's normal as it was yesterday. So sign it off, clear the cache, and let's get another abdominal CT scan from the emergency department. This is a 24-year-old male patient. This is a contrast enhanced scan, and it says nothing about why this scan was ordered in the first place, but we can actually click here in a few buttons that you guys can't see, but I can see on the reporting platform, and look for a motive for scanning this very young patient, 24-year-old, and it says this patient has pain on the lumbar region on the left, so it's left-sided back pain. Let's look for kidney stones. But it makes no sense to do a contrast enhanced CT scan for kidney stones, but no. Computed tomography isn't always a rational thing, if you know what I mean. So let's see, this is pre-contrast non-enhanced phase, and this is a portal enhanced phase. This is a very old scanner, a crappy scanner, so don't expect much. Let's see what we can say about this. Oh, the patient kidneys are fine. There is no signs of kidney stones, calculi or calculus. Spleen is okay. Pancreas is fine. Great vessels and portal vein are fine. The bladder, the urinary bladder, is normally distended. The prostate and the seminal glands are fine. Rectum and anal region are fine. Colon is fine. colon is awesome. Is it possible to see the appendix here? I guess it's around here somewhere, but I can't really tell if it's here because this is a very bad scan and there is no endorectal, no rectal retrograde contrast enhancement whatsoever. I can't really say there is any kind of disease that could justify left lumbar pain, except if we find anything on his spine. The spine is quite normal. So, normal vertebral column, vertebral spine, yuppers, and a really normal abdominal scan, enhanced abdominal scan, which is something we just don't see every day. This is a very, very rare case of an emergency enhanced abdominal scan that I'll be obligated to report as normal. So, yep. It's been quite some time since I last reported a normal abdominal scan. So let's go. Let's sign this off, clear the cache, and go for the next one. So we have here a paranasal sinus exam. It says sinusitis. Yep. So this should be fun. I like paranasal sinus phase CT scans. They are usually peculiar, to say the least, and sometimes we actually diagnose major disease on these scans and end up helping out the patient much more than the referring doctor ever expected us to help. So this is axial. Let's hit MPR because the best projection to analyze paranasal sinus is the coronal one. So this is the coronal and this is the axial. I can't really care much about sagittal views. I'm gonna keep the axial here so you guys can have a notion of what I'm looking at. So this is the nose, eyes, nose, front and back. So I'm looking at the orbit because I have already seen the sinusitis all over the place. This is a soft tissue window to look for tumors. There are no tumors. There are no tumors. So the next step is hit the bone window and see how bad this sinusitis is. So there is anomalous content and thickening of the mucosal layer of the nasal cavities and the paranasal sinus, especially the maxillary sinus. See? This is thickening of the mucosa. Frontal sinus are also affected. The ethmoid cells are also partially filled with anomalous content. The sphenoidal sinus, on the other hand, are really normal, preserved, can't say much about them. And there is clear signs of obstruction of the drainage of the frontal sinus and not the maxillary sinus. So the maxillary drainage, the osteomeatal complexes are fine. I can see the middle nasal concha and the upper nasal turbines are filled with air. They are enlarged and filled with air. In Portuguese, this is called cornetos bolhosos, and I can't really tell the name of it in English. I'm sorry. Also, the lower nasal turbines are enlarged, which is very common on sinusitis patients. So, temporal mandibular joints are fine, and temporal bones and the ears are okay, except for some anomalous content on the external auditory canal to the right. So, this is a very common case of acute sinusitis. The septum, the nasal septum, is a bit tortuous, but it's rather fine. So let's report it. Feel free to skip ahead if you don't want to watch me mumble and write and type stuff on the report. But if you want to learn a bit more about this case, just stick around. I'll sure spit out something that may be of some kind of learning experience to you, as it is always to me. So there is thickening of the mucosa all over the place. The drainage, sinus drainage is okay, except for the frontal sinus. And there is air and enlargement of the middle and superior concha. And enlargement of the lower ones. Oh, let's see the Kiros classification. It's 3. Kiros, yep, over 7. And there is a right-sided inclination of the fovea. Mandal fovea. So I'm just summarizing the report in the end, make it easier for the referring physician. And this is it. We have finished yet another case. Let's sign it. And it's signed. Let's clear the cache of the images, and let's just do a dorsal spine CT scan. Dorsal spine CT scan of a very old patient. It's a 75-year-old patient that complains about dorsal pain. So, yep, it's downloading. It shouldn't take long. Let me get my template, dorsal spine CT scan template. 75-year-old should have a bunch of degenerative disease, maybe some fractures and a bunch of stuff. So it's downloaded. Yes, this is major, this is really bad. Let's see how bad it is. So there is a forward arching of the spine. I can clearly see there is a compression fracture right here. There is air in between these vertebral bodies, which points out to advanced disease. There is a lot of osteophytes, also sclerosis and deformities of the vertebral end plates. So this is chronic disease. This is a chronic disease, and the pain comes from here because this is a new fracture. This is a new fracture related to osteoporosis, to bone insufficiency. So the bone is really weak. You can see that it's really hypo-intense. It's really hypodense, which means there is very little bone density here. So this is a weak spine with advanced degenerative disease, and this vertebral body has suffered a fracture. This isn't a dorsal fracture, it is actually a first lumbar body fracture. It's L1 body fracture, but I'm going to report it because this is probably the cause of the painful complaints, with painful symptoms the patient is complaining about. So it's just degenerative disease and a acute fracture of the vertebral body. Let's get to the end of this. There is really no major protrusion nor extrusion of discs, no bulging discs. There is, of course, chronic denervation of perivertebral muscles, which is shown here by atrophy, hypertrophy of such muscles, and there is at least moderate arthrosis of both the facet joints and the costovertebral joints, the joints between the rib cage and the vertebral body. So much osteophytes. This is a pretty common and exam to report, so this is a lesson to be learned for sure. So I'm going to report this case, and then we are going to go to our last exam of this video. So if you want to stick around. If you haven't already, hit the like, subscribe to the channel so you won't miss new videos, and be sure to turn on the notification bell. And if you are so kind, please share this video with people you know enjoys diagnostic radiology. Thank you so much for your audience. Thank you so much for watching. So I have to say there is diffuse reduction in bone density, which in Portuguese I type in as desmineralização óssea difusa. Oh, and there is a fracture. Acute fracture. and partial collapse. Here the other bodies aren't fractured. Yep, there is arthrosis. Yep, all joints are bad. No. Severe spondylosis and hypertrophy of perivertebral muscles. Yep. I'm just going to summarize this report before we go to the last one of this video. Yep. Oh, just mistyped something. Hypertrophy. Yep. So this is a insufficiency fracture on a spine of a elderly woman related to osteoporosis. This is really common. It's quite painful. So lesson learned. Let's keep on reporting. Let's clear the cache. Sign it off. Let's go. It's taking a bit to sign this one. Go. Sign it. Come on. So you are already over 1 hour in. I'm sleepy, I'm sorry. Sign it for God's sakes. Yeah, it's signed. So just to end, let's see another chest exam. I know you guys enjoy chest exam. This is a 36-year-old female patient that says she goes out of breath after a physical exertion, so she can't. That's all. I do too. I always have no endurance because I just sit around and report exams all day long. I don't exercise at all. So I know I should exercise. I just can't right now. So does our patient. It's a female patient, 36-year-old, that complains about shortness of breath related to physical exertion. So let's go. Download is done. We have lung window right here. This and mediastinal soft tissue. I hate when this happens. Oh yeah. So let's go. This was So we don't really expect to find much here. Excuse me, I'm sleepy, really. And I had a good night's sleep. I'm just tired, maybe. Or old. Maybe I'm just old. And axillary regions are okay. Breast tissue seems symmetrical. We don't really expect to find much here because it's really not supposed to be anything really. Physical exertion should lead to tiredness. So, but anyway, yep. Heart, vessels, lung parenchyma, soft tissue, structures, great vessels, mediastinum, pericardium. It's all fine. Let's try out a MPR in a second to see if we can notice anything else on the bones. Bones seem fine. Even the shoulder blades, the scapulas, and the humerus. So, sagittal. Let's see. This isn't a perfect exam. The MPR isn't great, but it's good enough. Sternum, some degenerative disease of the spine is fine. Patient is quite young, but it seems she is suffering of some kind of back pain, because this ought to be painful, at least in some sense, in some situations. Rib cage seems fine, as much as we can tell on this kind of exam, and there isn't much to tell. This case isn't much at all, so just report. Yep. I have to tell in this kind of exam that there is no signs of acute pulmonary disease, just to be sure that I have actually looked at the lungs and I can tell with confidence that there is no lung disease that justifies the complaints of shortness of breath. I guess this is the motive, after all, of ordering this CT scan. So I actually say this on the summary of the report, that there is no sign of acute pulmonary disease. So everybody goes home happy. And so this is it. I hope you enjoyed this video. Click here to watch the next one, and don't forget to hit the like button, subscribe to the channel, and share this video with people you know enjoys diagnostic radiology. Thank you so much, and until next time, I'll see you around.